Hi, everybody. I'm Dr. Carolyn Alexander, and I'm looking forward to speaking today with you with Dr. Mark Surrey, my partner. I'm sorry we're a few minutes over, but I'm excited to chat and talk about any questions you guys have. Our topic of discussion today is what we should know about fertility. And we both work at Southern California Reproductive Center in Los Angeles. And our Dr. Surrey's been a leader in the field of IVF, and we work really hard to provide compassionate care to all our patients with an individualized treatment plan. And I'll have Dr. Surrey talk about his background too in a few minutes. I'm Carolyn Alexander. I grew up in LA, and I'm excited to be a part of the team here. We're very dedicated and put a lot of effort and thought into helping you through your fertility journey and deciding which strategy to approach. And it's just a pleasure each day to help patients. Next slide. Our embryology team has worked really hard. We've had our embryology lab for over 25 years. It's a state-of-the-art embryology lab. We have an on-site surgery center. We are in Beverly Hills. We have a Pasadena office, and our Santa Barbara office also has a fantastic embryology lab too, with a very high pregnancy rate. We work closely with Dr. Surrey, Dr. Hal Danzer, and Dr. Susan Maxwell. She's in Santa Barbara. And like I said, we just put a lot of thought into each patient. Next slide. So it's important to have experienced embryologists. We have a double witnessing verification plan here. We have flash freezing for the eggs and blastocysts or embryos, and that has had the highest success with survival of the thaw. We do pre-implantation genetic aneuploidy screening, as well as genetic screening for specific genetic mutations that you or your partner may carry, or a combination. We also can do sex selection. We have the EmbryoScope, which is a time-lapse video analysis that helps us differentiate between embryos by using 1,000 data points to understand which embryo could be potentially a higher chance to get a live birth than a different embryo. So it provides a lot of information. We have certified directors, collaboration with other accredited labs as well. And it's a fantastic team. They have a lot of good energy in there. Next slide. So we're going to talk about what is the definition of infertility, the age factor. I know how it is. I started having kids later in life, so I understand that feeling. We'll talk about pre-testing and how to prepare your body, the fertility treatment options, and Dr. Surrey will talk about embryo development and genetic testing, embryo transfer protocols, and our promotions. And we're happy to answer any questions through the chat. A lot of these webinars, we're asked questions that are so amazing and good and important. So it's good to talk it out. Next slide. So what is infertility? It's very important. It's 1 year of unprotected intercourse, usually with regular periods when we're under 35 years old. When we get over 35, we typically say it's a balancing act of our age. And so 6 months of unprotected intercourse with regular periods where we're hoping you're ovulating and not getting pregnant is the definition of infertility. And it's always a little mind-boggling why nature does this, but as we get older, the quality of the eggs and the risk of genetic chromosomal abnormality starts to go up. I always believe there's always a good egg, but it's important to understand that as time goes by, the ovaries can age as well. And sometimes with other health conditions, the ovaries can tend to have diminished ovarian reserve younger than we would predict based only on our age too. Next slide. In terms of genetics, so as you can see here, on the right, the normal eggs that are genetically normal starts to go down when we turn 30, but really traditionally it's around age 35 that every other egg starts to not have a healthy chromosome complement. And that can be due to the stickiness of the chromosomes at the mitotic spindle when the chromosomes separate when fertilization occurs. And so some of our patients, our average age of patients is 39.9, so they're towards 40. We're used to helping and jumping in and doing everything we can to do our best to get healthy eggs. So it does start a lot of times with lifestyle modifications, vitamins, lowering your stress, amping up exercise if you're not exercising too much, or lowering exercise if we might be over exercising, and thinking about a few other lifestyle things too. In terms of the graph on the left, every time we ovulate, the chance of conception is there. But what's interesting is our peak fertility was in our earlier 20s, where fertilization of an egg is around 22% when we were younger. And as time goes by, it just starts to go down. And so it's interesting, the month-to-month opportunity to get pregnant starts to really shift when we do turn 35. Next slide. And the picture on the left is an image of the ovary, and each little circle has an egg that's smaller than a grain of salt. And each of those shows that that cortex, or the outer rim of the ovary, has a lot of potential eggs. As we get towards 50 years old, in the image on the right, you can see a very limited amount of eggs remain. And that's because also there's apoptosis, or this constant drive of each pool of eggs every month to have one ovulate and then the rest vanish. And so there's this continuous sort of interesting decline in our egg supply as we get older. And it's important to recognize this, but not be too fearful, because sometimes patients will say, oh, I wish I knew this, or I wish I thought about this sooner. But you can't look to the past. We can only sort of stay razor focused on the future. Next slide. So there's important tests. One is called AMH, anti-Müllerian hormone level. It's not a perfect test, but it's a blood test that can be done any day and anytime. And it takes about 7 days to come back. And we're hoping for it to be in the normal range. So from age 26 to 29, normal's 1.96 to 5.88. When we're 30 to 35, normal's 1.4 to 4.2. When we're 36 to 39, normal's 0.84 to 2.8, but typically we want it above 1 at that age. 40 to 44, 0.42 to 1.4. And over 44, we do still have pregnancies, but the chance of the egg supply going down when we get into our 40s starts to be a big risk factor. The image on the right is called the antral follicle of an ultrasound. It's a vaginal ultrasound where we're able to count the little circles in the ovaries, and each of those has a potential microscopic egg. The other blood test that a lot of people talk about is on your second, third, or fourth day of your period, and it's called FSH, follicle stimulating hormone, with estradiol. Those go hand in hand. And we have certain levels we're shooting for different patients. And we want the FSH below 10 typically, and the estradiol below 60, especially when you're on your menstrual cycle. Next slide. The male partner testing is important. We do see a lot of patients who, after a year of trying, will do a semen analysis, and lo and behold, the sperm count is very low. And so it's important to check the volume is over 2 milliliters, the concentration over 20 million per milliliter, the motility over 50% swimming fast, and the morphology, or the shape of the sperm, over 14%. And studies indicate that 25% of infertility is primary male factor, whereas 40 to 60% of infertile couples, it's a component of male factor. I like the image on the right where normal sperm has a normal head, normal midpiece and tail, and due to toxins, plastic pollution, sometimes medications can do this, as well as lifestyle, such as marijuana, CBD oil, vaping, excessive alcohol can impact the shape of the sperm. But what's beautiful about sperm is every 72 days you make a new batch. And so we have an opportunity to intervene and help men get better sperm quality, especially if you have frozen eggs. We really, really want to be cautious to optimize the sperm before you thaw the frozen eggs, because we have a chance to improve sperm parameters before we thaw the eggs. Next slide. Here at SCRC, we have a holistic approach. We talk about acupuncture, nutrition, meditation. I know when I was starting to think about trying to get pregnant, I really revamped my diet and I really started acupuncture. I amped up my exercise and I think it helped me. And sometimes when I think about it, all of us need a little reminder to do that. Next slide. And the benefits of nutrition, the Mediterranean diet has a lot of micronutrients with a lot of colorful fruits and vegetables, nuts and seeds. And a folic acid is very important to prevent spina bifida in the baby. A lot of people become B12 deficient because they may not be absorbing it. So it's important to have an adequate B12 in your diet. Omega-3 fatty acids are in salmon, cod liver oil, sardines, chia and flax seeds, and walnuts. So it's good to have a well-balanced diet too. In terms of your prenatal vitamin, we really want to encourage patients to start a prenatal vitamin with DHA. Take CoQ10, which improves the mitochondrial function of the eggs. And vitamin D levels has improved our embryo transfer pregnancy rate if our vitamin D level is above 30, and we really want to get it towards 50. So it's important to optimize your vitamin D level. Next slide. Men have to consider vitamins. Some men are taking a lot of vitamins and some of them can have additives in it that could be not optimal for sperm quality. So some of the ones that we encourage are called Proxseed Plus or ProFertile, and they mainly have zinc, L-carnitine, and they help improve sperm motility as well as possibly the quality. CoQ10 at a lower quantity than what women need to take can improve fertilization with the sperm. And then men who have low vitamin D levels may have an impact on their semen analysis. So we are now checking all the vitamin D levels. So it's good to keep that in mind, especially when you have your annual physical exam too. Next slide. Avoiding toxins is everything in moderation. It's hard for people to cold turkey what they're doing, but I always say, whatever you're doing, we might need to cut down by half and then reevaluate and maybe cut down again by half. But we really want to have less than 4 drinks per week, because there are some articles saying that if you have more than 4 drinks a week, it can impact live birth rate and pregnancy. And cannabis use is very common since COVID hit. We do see a lot of vaping and CBD oil and cannabis use. So everything in moderation, but usually it's safer to think about egg quality and sperm quality by limiting exposure to toxins in general, especially tobacco. Earlier menopause has been shown in women who use tobacco, and men's motility is lower with tobacco use. So we tend to say you're hopefully going to have a baby soon. And so it would be good to take the time now to use Chantix or whatever you need to do with your primary care doctor to avoid tobacco and really limit exposure to tobacco. Next slide. I'll switch it over to my partner, Dr. Surrey, and I hope everybody has a wonderful day. Thank you.
Carolyn, thank you. Am I on? Do you think we can hear? I think so. So wanted to first of all thank my partner, Dr. Alexander, for that excellent introduction. And for those of you who are interested in your fertility, I think the idea that she has mentioned about supplements and about avoiding toxins are pretty critical. So it really is of benefit to your fertility to do this and to follow these things. So we're going to go through a little bit of what we can do for your fertility. And we can do a lot of things. The first thing that you'll notice is there's a lot of freezing. Freezing is actually done by a process called vitrification, which is like a flash freeze that is very effective for preserving human tissue of any sort. So that goes for, interestingly enough, eggs, sperm, embryos. And, you know, the idea of egg freezing has been very challenging technically because the human egg probably contains more water than any other cell in the human body. And as such, it has tradition to freeze and thaw properly. The vitrification process allows us to do that. And for any of you who are considering preserving your fertility, it's essential that the lab that you choose uses this vitrification process. So it's important to know that you can preserve sperm as well as eggs, embryos, particularly well, that should be, if possible, genetically tested before being preserved so that you know that what you have is normal. And some of the things that we can do with this material, your genetic material, are inseminations, IVF, things like surrogacy and donor eggs. What's interesting is that people frequently are not clear about the difference between IUI, which stands for intrauterine insemination, and IVF, which stands for in vitro fertilization. And there's a very big difference between the two. IUI is natural fertility, and it's placing sperm that has not been exposed to eggs or fertilized through the cervix into the uterus based upon a lot of assumptions. The first being that it will meet an egg, then that it will fertilize the egg, and then that it will create embryos that are normal. Insemination needs to be done when a woman is ovulating. And we like to document that by looking at the ovaries with ultrasound. Ultrasound is a very accurate way to look at the progress of a follicle, which in theory should contain an egg and should be able to be fertilized if it's able to be by the sperm that will then create an embryo approximately 12 to 36 hours after ovulation. So it's not that it has to be done in a particular hour or day. There's a window of a couple of days here that you can achieve fertilization from an insemination. But again, an insemination is a natural process, and it presumes that a lot of things are going to happen that have to happen in the fallopian tube. So when they do, we don't see it. When we don't, we don't see it. So it's something that we'll presume is going to work, but the only way to see it work is with the in vitro process, because that's when we can actually observe the fertilization process as well as embryo development. And that's very different. As you can see here, the fertilized egg goes through a number of stages in the fallopian tube in order to achieve pregnancy. When that occurs in the fallopian tube, which has to happen with an insemination, we don't see any of this. So when it works, it's great, but when it doesn't work, we don't really know why. The in vitro process tells us the reason why, because it allows us to see the egg fertilize. It allows us to see the embryos develop. And this development to a blastocyst stage, at which time it can implant, takes about 5 to 6 days on average. Next. So when we do in vitro, the idea is to create more eggs and more embryos, because we know that not all of human eggs that are produced are going to produce a normal pregnancy. So more is better. It gives us an opportunity to evaluate different eggs and different embryos. We create more with ovarian stimulation. And the ovarian stimulation was with the natural releasing factors that come from the anterior pituitary gland, called FSH, or follicle stimulating hormone, and luteinizing hormone. And this is given underneath the skin for an average of 10 to 12 days, during which time we like to follow how your response is to this stimulant by looking with ultrasounds and hormone levels on average of about 5 times during those 10 to 14 days, during which time it allows us the how your response is. Next. So the response can be adequately evaluated by a combination of your ultrasounds, which show the development from early stage follicles that Dr. Alexander mentioned, to later stage to mature follicles. This is actually a needle that is being inserted internally into the follicle, from which the egg is aspirated, evaluated in the laboratory by looking at the fluid that it contains the egg, and the egg is then fertilized in the laboratory. And that's why they call it in vitro fertilization. Next. So it's done with single sperm cells into a single egg that looks like this, and it's very accurately injected. You can see the sperm coming in that way, and you can see that it is injected into the egg itself, thereby creating an embryo. So unlike insemination, we know that this is effectively achieving fertilization. Next. So this is what happens after fertilization. This is called morphokinetic embryo analysis, which we utilize with an incubation system that has a camera underneath the incubator. And this is about 5 to 6 days of embryo development. This is that blastocyst that we were talking about that's necessary in order to have an embryo develop normally and to implant normally. So with an insemination, you never see this. If it works, this has to have happened. If it doesn't work, it didn't happen. With in vitro, you see this happen, so you know what's going on. This technology is not something that all labs utilize. We utilize it because it gives us interesting information, like you can see here, about how embryos develop over the course of 5 to 6 days. But furthermore, by being in a closed system, not exposed to the environment, this happens more often than in a system where most labs utilize, where you take the embryo out and look at it every couple of days. So this is a very superior way of evaluating embryos. Next. So when an embryo is deemed to be normal by its evaluation, its structural development, and its genetic development, it's preserved and then thawed, and then transferred into the uterus in a small catheter, when the uterus is ready, as evidenced by normal ovulation in a natural cycle, or for people who don't normally ovulate, we can prepare the uterus with a combination of natural estrogens and progestogens. The embryo is loaded and transferred into the uterus, and then the test is done usually about 10 to 12 days after the transfer. Next. So cryopreservation, which we talked about from vitrification, is very effective. In our laboratory, 75% of the cryopreserved eggs are able to fertilize, half of which create advanced embryos that we refer to as blastocysts. The embryo survival rate is in excess of 95%, and the egg survival rate is in excess of 87%. Implantation rates or pregnancy rates are over 70%. So there have been lots of babies born with no issues as a result of cryopreservation. Next. Sperm freezing is also very effective and is an interesting idea for men to preserve their fertility. It's also possibly utilized for men undergoing sperm extraction, or for people who are out of the country, out of the area, and can preserve their specimens for utilization for in vitro. Next. So there are lots of different promotions that the office has that look to try to make all of this technology easy for you guys and more affordable. Next. And this is our team of clinical physicians. Dr. Alexander, you just met. Dr. Danzer is going to be available for anybody to meet, as will Dr. Maxwell. So we have a very fine team of clinicians and of laboratory personnel, and we're more than happy to answer any questions that you may have. And perhaps, I think Dr. Alexander is still there with us.
Yes. Yeah, I read through we got a lot of wonderful questions, and one of them is, if all the fertility evaluation's normal, but you've been trying for a year, what are the best options? I think as Dr. Surrey said, sometimes that egg and sperm interaction, for some reason, it can be unexplained, or sometimes there's microscopic endometriosis, which occurs in reproductive age women and affects a lot of patients with infertility. But sometimes unexplained infertility is that moment of egg and sperm interaction. And so when we have an opportunity to see it and actually place the sperm in with intracytoplasmic sperm injection, we can overcome that dilemma with IVF. There are other evaluations you could get done with your doctor as well, but typically it can be that. And I'd love to hear what Dr. Surrey says.
Yeah, I think that's a good point, that the idea of in vitro technologies allow us to do a really critical assessment of the issue of fertilization and early embryo development that we can't really know about without doing the IVF. So it's the ultimate diagnostic test for your fertility, in addition to a therapeutic effect, by creating a very high pregnancy rate in our lab, over 70%, compared to other technologies like the insemination, which are not as effective at all.
One of the other questions was, how long prior to egg freezing or fertility treatments should you consider the prenatals, lifestyle modifications, exercise, all the good things? typically 90 days for egg development and 72 days for sperm, but sometimes our patients are a little older or their AMH, anti-Müllerian hormone level, is a little worrisome. And so we don't have the luxury of a lot of time per se. And so we usually say at least the month ahead of really doing the best you can in those regards. I think that's helpful, but traditionally there's sort of this 90-day window where those vitamins help. Interestingly, you're born with your eggs in your ovaries, and so it's a lifetime of exposure to chemicals and who knows what that really probably impacts us. And it's not necessarily specifically that little window of time per se.
So Carolyn, that brings us to somebody's question about the chances of a successful IVF with high FSH of about 15 and an AMH that's low, 0.4. So these are indicators and markers of ovarian reserve, or the number of eggs that you're going to create. And these numbers look low, meaning that you're not going to create a lot of eggs. The question really is, well, does that predict the quality of the eggs? And that's really the issue about fertility and the chances of successful IVF, is that these follicles that create and contain eggs are being stimulated. You're not going to make a lot of them. So the question is what are you going to make? And the in vitro is what we talked about as the ultimate kind of diagnostic process to answer that question. So if you show us what kind of embryos you make, we can give you a pretty good idea of the chances of a successful IVF. Just knowing that you don't make a lot of eggs, is not sufficient information to give us to allow us to give you an accurate answer to your question. But if you had
age matters. A lot of the time we could get 4 or 5 eggs and a few fertilized and make a good embryo. In a young individual, we can get that embryo to be a healthy pregnancy. Even in one good try, we can do that. But typically when we're older, over 40, it's a little harder to get a genetically healthy egg, but it doesn't mean we couldn't. It just means it might take more tries. And so typically we try to pick protocols that help overcome the FSH from the pituitary gland in your brain, that's producing that level of a 15 of FSH. And so we have to try to navigate which protocol will help get the most eggs as well as the quality eggs to come up. Sometimes when I see FSH, I think, is that person under a lot of stress? Are they getting proper sleep habits? Should they think about acupuncture, meditation, mindfulness? It may or may not help, but at least it's something to try.
That's a good point. So FSH, AMH, these are markers that are ideas, but they're not that specific sometimes. But the idea that you've given us is that you don't make a lot of eggs. So the idea of a pregnancy occurring is going to be determined by the quality of those eggs, as evidenced by the quality of the embryos that you produce. So somebody had a failed IVF process and apparently wants to try an IUI, or an intrauterine insemination. How long should you wait to start the process? Well, you could probably start as soon as you're ready to ovulate, which should be, in theory, for the next month or so.
You just want to ask your doctor, but you want to triple check that the fallopian tubes are patent or open, because sometimes after a few IUIs, then we figure out that the fallopian tubes aren't open. And that's a lot of time going by if someone failed an IVF cycle. We don't want to miss the window of opportunity, let's say, too. I see a question that's really helpful. I always think of this question because we're asked every day, how many eggs do I need for a pregnancy? And so it really varies on each person as well as the future partner's sperm. But our lab did a 5-year retrospective look in our facility. At 37 years old, we needed 17 to 25 eggs to get a pregnancy. And there's no guarantee. I wish there was, but it was kind of a lot of eggs to get a pregnancy at 37. Typically when we're 35, we want 10 to 20, but it does sometimes take a higher number of eggs again, because there could be male factor, and that could impact how many of those eggs fertilize, which can cause a drop off on those eggs. So it's important to prepare for both people when we're ready to fertilize those eggs too.
So there is a question about a same-sex couple, and I think the factors to be considered are similar in regard to your ovarian reserve and your reproductive health, that require an evaluation, which would include imaging with an ultrasound and some hormone levels, to really answer your questions. But in regard to different options for same-sex couples, they really are focused on what's called assisted reproductive technology, since it's necessary to create embryos in the lab. That's the in vitro process. And then it may be necessary, depending upon your situation, to either, if you're males, to have an egg donor and a surrogate. And for women, you don't need that, but those are options. So I think it's very important to have an evaluation done, regardless of who you are, to try to answer these questions. So there's a question about unexplained miscarriages.
Yeah.
Carolyn, do you want to?
Sure. Yeah. With miscarriages, we kind of categorize it into 5 kind of bigger categories. Generally speaking, the biggest part of the puzzle is the genetics of either the egg or the sperm. And so it's important with recurrent miscarriages to double check that both partners' karyotype are normal, and the genetics that you carry in your egg and sperm are that they're not aneuploidy or balanced translocations. The other thing is the uterine cavity evaluation. So checking that the uterus doesn't have a fibroid, polyp, or scar tissue that causes recurrent miscarriages. That's relatively easier to fix, because that's kind of one of those things that we catch and it's easy to fix. The other part of the puzzle is antiphospholipid antibody panel, or a thrombophilia panel, to check that there's not a hidden blood clotting disorder. Sometimes we work closely with immunology or rheumatology to look carefully at the immune system. We do occasionally catch a blood test called lupus anticoagulant, which is important for blood clotting disorders as well. And then checking the vagina for ureaplasma, mycoplasma, and things like that. And checking the man, because we noticed sperm DNA parameters, it's called sperm DNA fragmentation, can be altered, and that may not always be that the woman or the uterus or the immune system's the problem. It can be a component of the male factor as well. And then sometimes it's idiopathic, which means we look at all the categories and we can't figure out what the problem is. And so those ones are a little more frustrating to figure out.
There's another issue here about a cerclage. And, if you have a cerclage, probably best to carry a single pregnancy as opposed to multiple pregnancy. So that's a general rule of thumb. There's something, Carolyn, about wanting to know at age somebody over 45, a good AMH and FSH number.
Yeah, we keep a little tab of the patients over 45 that we're lucky to help get them pregnant with a biological baby of their own, not with frozen eggs that they froze 10 years ago. And it's always interesting because some of the patients are really outliers where their AMH is so good. Their body has a better supply than most people at 45. But there's not like a hard, fast rule of what to expect, because typically at 45, the AMH starts to go down and we can't control it. But generally speaking, we would want it to be towards 1 if it was possible. And people say, I want to control that, but we can't necessarily control it. FSH can fluctuate each month, and so there's not a perfect month where it might be perfect, but sometimes we'll catch FSH less than 10 in a 45-year-old, and we think that could be a good month for good egg quality. But generally speaking, FSH also starts to go up as we get older on the 3rd day of your period.
So Alexa, I think that preserving your fertility for the future is a valid process with or without a partner. So just so you know, you cannot accurately genetically test unfertilized eggs. You can, as you know, accurately test fertilized eggs or embryos, but whatever it is that you're doing at age 31, in theory, it's going to be better than what you're going to be doing at age 38. So I think the idea of fertility preservation is very functional and very relevant with or without a partner. And if it's without a partner, then it's by preserving unfertilized eggs.
She had a second part to the question, which was genetic screening for Fragile X, cystic fibrosis, Tay-Sachs. The only reason to do it is the Fragile X, if you have a pre-mutation, which we don't catch often, but every once in a while, a woman wanting to freeze her eggs will catch that she has a Fragile X pre-mutation. When we talk about how many eggs for a live birth, we actually have to double the number because the Fragile X can expand in some of those eggs and cause problems. And so when we look at statistics, it's a little different if we knew the patient carried a genetic mutation called Fragile X. But generally speaking, our patients don't all do genetic screening before egg freezing because sometimes they just prefer to wait till they have a partner to do screening for general autosomal recessive disorders in general. Yep.
So you had a leap done at 33, and how would it affect the pregnancy in the 40s? It may not, but it's important to have your cervix checked when you're ready to have a pregnancy, because it's important to know the competency of your cervix, which could have been affected by this LEAP procedure. Carolyn, any other thoughts about
Yeah,
that?
sometimes the endocervical canal from having the LEAP has the glands to have a little less mucus. So occasionally patients might need an IUI where sperm's just placed in up above to the top part of the uterus. And so it sort of bypasses if the cervix is having any problems or obstacles. But generally speaking, most LEAPs don't cause us many problems. But in pregnancy, they can monitor your cervical length, and you might need to advocate for yourself that, you know, keep an eye on your cervical length because you knew you had the LEAP. But yeah, it's typically not to be too alarmed about, but it's good to think about it.
So Lauren, about the immature eggs that needed to be mature in a lab, if it is able to mature satisfactorily, it has a very reasonable chance of becoming a healthy baby. And so those eggs are not necessarily unreliable, as you might have imagined. Carolyn, any thoughts about that?
Yeah, I think the late maturing eggs, I've had many pregnancies with them that fertilize and grow to the blastocysts. So it is helpful to see that some of the eggs become mature later, and we are very proactive here with those eggs too.
Thank you, everybody, for your attention. And if anybody would like to ask any of us any further questions, we're happy to speak with you on the phone or to see you in a consultation. And if you just call the office number, they can connect you with us, and we're happy to try to answer any questions you might have.
Have a wonderful day, everybody. Take care. Bye-bye.
You will. Thank you. Bye-bye.